Welcome to YouTube number 3, the third part of a 3-part series on how to read a paper, and we're going to again follow up along our case of patient with acute sciatica and comparing pregabalin and placebo as our case example. Hope you find it useful. Just a recap, on the last time in the first YouTube clip we covered question type and study design and PICO of the paper, and we're looking at that with a view to how well this is going to compare with the patient or group of patients we had in mind. In YouTube clip number 2 we went on about assessing internal validity, so do I trust the results, which is where we really look at the through using a checklist at the effect of bias on a paper and how well distributed prognostic variables were in terms of whether they're equal or unequal. And in this final part of the series we're going to look at results and the things that we do when we look at results, and then assess the external validity, which is how can how can these results help me look after my patients. So I hope you find it useful. So just to recap, there's 4 possible explanations for any result. There's the possibility the result is actually true. There's the possibility of chance, bias, or unequal distribution of prognostic variables. And you may recall in YouTube clip number 2, when we assessed the internal validity, we addressed bias, and in this particular article on pregabalin we found it was reasonably low in bias. Not perfect, but reasonably low. And we noticed that there was we identified a mild unequal distribution of prognostic variables as regards the primary outcome. And so these are the 2 that we've addressed with the internal validity, and that leaves us with chance, and it also leaves us with the fact that we have to address that identified unequal distribution of prognostic variables. So these are 2 challenges in the results section. Yeah, so this would be my system for addressing, for approaching the results part of a paper. I would do this initially with the primary outcome in mind, because that's the main outcome that we draw real conclusions from. But I'll also do a similar thing with the secondary outcomes, just not spending quite as much time on it as secondary outcomes ultimately are just hypothesis generating. So the first thing I do is I look at the primary outcome or the outcome expressed and decide what is it expressed as. Is it a difference or is it a ratio? So an absolute difference or a ratio. I look at the 95th percent confidence interval, which gives me an idea of the precision of the value that I'm seeing, of this result I'm seeing, and then look at what the magnitude of the result is. Having done that, I then make sure that this result has been adjusted in some way for the unequal prognostic variables, and there's a variety of ways that papers do this. This is not an area that I think you need to know in great detail at this stage. It's a more of an advanced sort of topic, but I will touch upon that to an extent. We then want to know, was the result due to chance? And this is an area that you do need to know quite well, and there are 2 possibilities. One is that of a paper where there's a positive result, and the other is where there's a negative result. We then try to make the result more clinically meaningful, and we'll show you how to do that. And then, as I said, I go through the similar process for the secondary outcomes, especially those related to harm. And then I decide a sort of more philosophical question of, what do these results say about the truth of the universe? It's a paper may make a certain conclusion from its result, but there's this bigger process where you're thinking, well, what does all the literature say, and where does this fit in? And we'll go through that. The one we'll use is the Bradford-Hill criteria, which is very useful when you're looking at papers that look at causality, so particularly harm papers and therapy question papers, such as this. So let's start with that first question. We're starting with the very first part of it, which is, how is the primary outcome expressed, how the result expressed? And there are 2 ways we can express a result. The first is as a absolute difference. What this means is you look at, say, at the outcome of interest, and you look at the risk of that outcome in the treatment group, and then you look at it at the risk of the outcome in the control group, and you look at what's the difference between those, so one minus the other. And this is what this particular paper that we're looking at on pregabalin expresses its result as. And these results are very useful because you can instantly convert them into number needed to treat. So if I said that there was 5 more events per 100 people in the treatment group compared to the control, I can actually convert that to, that means I need to treat 20 patients to prevent 1 event. So that's how it works. So it's clinically quite meaningful. Well, it's very easy to make it very clinically meaningful. The problem with it is that it already takes into consideration the likelihood of that event in the study group. So, for example, if I had a medication looking at preventing stroke, say drug X, and I'm comparing it with the placebo, if the risk of a stroke went from 8 in 100, which is the risk in the placebo group, down to 2 in 100, which is the treatment group, that means there's an absolute risk reduction of 8 minus 2, which is 6 per 100 people. And that might be how the study chooses to express the result. And the problem is, if I've got a patient in front of me whose risk of having a stroke in that same time period was 1 in 1,000, well, those numbers don't apply very well to them. You actually need to convert the result into the other way that results are expressed, which is a ratio, to actually draw some meaning from my patient. So when a result is expressed as a difference in a study, you do need to ask yourself, does my patient have the same risk of that outcome that I'm trying to extrapolate these results to? The other thing to say about absolute differences is the way that you express magnitude of effect is that no effect is a risk, is an absolute difference of 0, and and if it's more than 0, then it's usually in favour of the medication, and if it's less than 0, a minus number in other words, it's against the medication. So that's sort of how we do magnitude. The other way that results are expressed is as a ratio. So this is, instead of minusing one result from the other, you're dividing. So it's 1 over the other. That's why you call it a ratio. And so common ratios are the relative risk ratio, there's an odds ratio, there's a hazards ratio. That'd be the big 3 that you commonly hear. And the idea is you're saying, what's the risk of the event in the exposed, i.e. the people who had the medication or the risk factor of interest, over the risk of the event in the underexposed. That's what a relative risk ratio would be. And you can have a look up definitions of odds ratios and hazards ratios. You'll find there's that similar concept of one thing being over another. The problem with these is to make them meaningful, you often got to then convert them to an absolute difference, so an absolute risk reduction in the case of a relative risk ratio, and then from that you can convert it to a number needed to treat. But in doing so, you've got to put in the likelihood of the event in your patient. So so basically you have to convert it you have to take into consideration the baseline risk of the event in that population you're wanting to extrapolate it to do that. But that's quite useful. So if you think back to that example of, let's say a drug that reduced stroke by 75%, well, so the relative risk reduction was 75%. Well, if I know that my patient in front of me has a 1 in 100, has a 1 in 1,000 chance of the event, I can actually multiply those things to work out my absolute risk difference, and then I can convert that to a number needed to treat, and suddenly I've got this meaningful result in front of my patient, even though my patient wasn't similar to the patients who were actually in the study. So that's its sort of so that's its real value. Now, in terms of magnitude of effect, well, ratios, the rule with them is if the value is 1, that means there's no difference, which is different to, if you remember back, absolute difference, the magic number there is 0. That means there's no difference. So ratios, it's 1, absolute difference is it's 0. And if a ratio is greater than 1, that's usually in favor of the medication or the exposure, and if it's less than 1, it's against the medication exposure that you're testing. So that's how we think in terms of these. So it's good to reflect on those. There's some nice video clips from Terry Shanafield if you want to just reflect on it more. And so if you have a look at this, the results in our paper, so how did they express the result here? Well, they expressed it, you can pause the video if you want, but basically it says there adjusted mean difference, so it's a difference. So it's one thing subtracting another. So what they've done is the outcome was a pain score from 0 to 10 at the 8-week mark for leg pain, and they subtracted that pain score out of 10, the mean pain score in the pregabalin group at the 8-week mark, in the control group, so the placebo group, from the pain score of the group who were getting pregabalin, and that gave us this mean difference. And the difference in that score between 0 and 10 at the 8-week mark was only 0.5. So there was only a reduction in that visual analog, 0 to 10 scale of 0.5 at the 8-week mark. Now, the other thing we talked about when it was, you might remember, is confidence intervals. And what confidence intervals do is they give a precision estimate of what the real value is. Because one of the problems with chance is that if you kept on sampling that same population in your study, you'll get different results just by chance. And so they want to counter for that. And because it might be if the result, if you picked if you just did it once, you might get an inaccurate estimation of the true result. And so what they do is they say, if I was to sample 100 times from that population and repeat the study, what would be those values 95 out of 100 times? So if I was to sample 100 times, well, 95% of the time, that result, that was in this case 0.5, would actually be somewhere between minus 0.2 and 1.2. And that's the result that you're actually looking at when you're trying to work out the magnitude of effect. It's not so much this one, it's this. So you're thinking, well, the magnitude of effect of this mean difference result crosses 0. And therefore, I don't think there is actually an effect, because when I keep it on sampling enough, some of the time those results crossed 0 into the negative number, which when you're looking at mean differences means there's no effect. So that's where confidence intervals come in. They help you determine the real result, and then you can determine whether it's a positive or negative study. So this is actually a negative study. There is no result. If that result had been positive, then you'd be interested in exactly what that number is. The higher the number, the more the magnitude of effect. Yep, so far what we've done is we've looked at the first part of results, which is knowing what the result is. Is it a difference or a ratio? We've looked at the confidence interval, and based on that, we've been able to work out the magnitude of effect. Is it a positive or negative study, and how strong an effect was it? So that's what we've done so far. And in this study, it sounds like it's a negative study because when you look at the 90% confidence interval, it crosses 0, which is no effect when you're looking at differences. So the next thing we do is we need to somehow take to deal with the slight unequal distribution of prognostic variables. Now, this is something which is a bit complicated, and that's why we didn't put it in the assignment. And I don't think you need to know it in detail, but it is worthwhile knowing it's there and just having a rough idea. And for those that want to become really good at studies, it probably is worthwhile, getting a little bit more knowledgeable about them. And there's some great Terry Shanafield videos that I recommend, and I'm sure there's other things on Google that you can find as well. But essentially, there are two types of, the things I just wanted to point out is that there's two main types of unequal prognostic variables. There are these things called confounders, which is where there's a risk factor that's associated with the outcome and also with the risk factor or treatment you're studying that is unequally distributed in the treatment or risk factor group and the control group. And an example of that would be the hormone replacement studies versus placebo on cardiovascular events, the cohort studies. Hormone replacement users tended to be more often to be diabetics, so there were more diabetics represented in that group compared to the people not on hormone replacement. And we also know that diabetes is associated with the outcome, which is a cardiovascular event, and therefore it's a confounder. And these are things that we try to minimize, and there are certain methods of dealing with them in the results. One you might have heard of is a multivariable analysis. That's just an example of how we would deal with it when you're looking at the results part of the study. The other type are called effective modifiers. These are biological variables that biological phenomena. They're where a variable can modify the effect of your risk factor or treatment of interest on the outcome, and they often have a dose relationship effect. So, for example, age can often be a modifier for certain risk factors or treatments on the outcome, and they're dealt with differently. We actually do what we call subgroup analysis, where we actually show that, say, different age ranges, that the higher the age range, the greater the effect of the risk factor or treatment on the outcome. So it's sort of dealt with differently. You can actually learn something biologically about health with these. And again, these are approached with these in effect a different way. These special subgroup analysis with different degrees of the risk factor or of the different degrees of this effect modifier in action and seeing what effect it has on the outcome. So they're dealt with differently. I don't think you need to get bogged down in all how they do them. Most studies do this area fairly well, but it's just to be aware of it. And I guess a practical implication is that is why in these studies they use words like adjusted on. You notice that this word adjusted appears on the result here. That's what they've obviously said. What they're basically saying is, look, we know there's some unequal prognostic variables. And in particular, when they adjust it, it's usually for confounders. And they've put a few of these unequal prognostic variables into some kind of mathematical formula to adjust to the raw result. And that's when you might have heard the word raw result. That means it's the result you use before you adjust it. So this is often the one we get interested in. That's why you've got that term there. The other thing is, and this is probably a bit too advanced, but I just mentioned it briefly, is that if you look at the statistical section of the paper or the results, you often find how the paper's trying to, little ways that this paper deals with these different phenomena. So you might notice here, primary outcome this is in the statistical section, primary outcome was analysed with the use of repeated measure linear mixed models. That just means a mathematical model that deals with some of these, what are in this case confounders, so leg length, pain scores, baseline leg length pain scores, duration of leg pain. So that's what they're doing here. And you might notice that they've made use of, they said subgroup analysis, where for pain detect score. So they're basically saying, well, here's another unequal prognostic variable, and this is how we've accounted for this. And you can see here's another one for additional therapies that people had. So they've there are ways that they're saying this is how we've dealt with these various unequal prognostic variables. And I think that's as much as I want to say. As I said, it wasn't in your assignment, but I think it's good to know for those people who really are, serious about knowing how to read a paper. So the next thing you do with a result is you ask, is the result due to chance? So now there's two types of chance. There's a chance that a result is negative in a study, as it was in our study, when the truth of the universe is there really was in that study a real result. It's just that we didn't have enough people in the study to pick it up. And then there's the other type of chance, which is where you find there's a positive result. So you find that pregabalin was more effective when the truth of the universe is it wasn't. And they both get sorted out in different ways. So in this particular study, the problem we have is we have a negative result. And so our challenge is to make sure that that result wasn't due to chance, that it wasn't that the truth of the universe there was a positive result. We call that a type 2 error, if you want to be fancy, or a beta error. And the way we get around that is we want to make sure there was enough patients in the study to make that statement. Because in small studies, you'll find there's a negative result simply due to chance because there's not enough patients in the study. So the way we get around that is we go to the statistical analysis section and see what was the primary outcome. You look at what we call the power. So 90% power means a 10% chance of one of these type 2 errors occurring. 80% power means a 20% chance. 70% power means a 30% chance. And we accept 20% or less. So this study aimed to be 90% power to detect a clinically important difference in pain scores in those on pregabalin and those that weren't of 1.5 points. And they said that to do that, we'd need 204 patients, 102 in each group. So I then go and I then looked and see how many patients were actually analysed. Did we get above 204? Ideally 1 or 2 in each group. And you can see here that we did. We had 106 analysed in the treatment group and 101 in the other. That's pretty close. That's close enough. I mean, we got above it. Would have been nice if it was 102 in the non-treatment arm, but that's close enough. So I think it is roughly 90% power. So that means that the chance of an error is 10%. I'll have one of these type 2 errors. In other words, the chance of there being a negative result when the truth is that there was a positive result. And we accept less than 20%. So we give this study a tick in this regard. So that means that, so if you think about it, this study is low in bias. It's taken into consideration, there was some slightly unequal distribution of prognostic variables, but they have adjusted for those in their results through a combination of adjusted results and doing some subgroup analyses. And the chance of the result being due to chance is low because of of that type 2 error we've just shown as being low, which means by deduction, this result is probably true of the population in this study. Now, just as a variation, if let's say the result actually was a positive study, so here's a result saying that the mean adjusted difference in pain scores between the pregabalin and the non-pregabalin group at 8 weeks was 5, with a 95% confidence interval of 2 to 7. So if I repeated the study, that result is still going to be somewhere suggestive of a positive study because it's above 0. So it's going to range between 2 and 7. So we've got a positive result, say, in favour of pregabalin. Well, how do you account for chance there? Well, here the chance error is that the result was positive when in the truth of the universe is the result was negative. And the way we account for that is we'd go to the p-value. And what we want to do is make sure that's less than 0.05. And if it is, we consider this result unlikely to be due to chance of this sort of type, which we call a type 1 error. The way that you can think of a p-value is that if we presume is that what they're saying by 0.02 is that there's a 2% chance that this result occurred when the truth of the universe is that there was no difference between the drug and the placebo in their primary outcome. if that had said, if that was 0.04, I'd say then a 4% chance. So you can see how that's sort of being expressed. So that's how you, if this study had been a positive study, that's how we would do it. And that's why we had that question in the assignment as a variation, just so you could appreciate that. Yeah, so now the next challenge is that we're going to try and make the result more clinically meaningful. If I think of a diagnostic study, so if I want to know how an ISTAT compares to a full blood count, the raw result would be the result that they'll give you will be a sensitivity and a specificity, but to make that more meaningful for a patient, we convert it to positive predictive values or negative predictive values, or probably even more meaningfully, positive likelihood ratios and negative likelihood ratios. And from these you can actually see how a real result actually affects the likelihood of a diagnosis in a real patient. So you're making things more meaningful, and then you would look at the harms of that diagnostic study, and then you balance the two. Well, in a therapy study, it's the same. They're all studies essentially the same concept. You've got this concept of looking at the benefits and the harms, and with the benefits, you're going to try and make it look more clinically meaningful. Often raw results are expressed as relative risk reductions. So if I said to a patient, you've got a relative reduction of 0.7, what does it mean for you and I? It doesn't instantly compute and translate into, and then if you're trying to compare that with the harms, it's harder. So we need to make these results more meaningful. And the way you do that with therapy studies, and the same with harm studies, by harm I mean, like does brain cancer, mobile phones cause brain cancer in a cohort study, is you look at that raw result, which might be a ratio or a risk difference, and you try and convert it to something more meaningful. And the way we do that is, if it's a ratio, you add in, you look at the baseline, risk of the outcome in the patient, and can convert it to a risk difference. Well, some studies, as in this pregabalin study, will actually give you the risk difference, and from that you then convert it to a number needed to treat. And so what might be a gobbledygook result, like relative reduction of 0.7, suddenly becomes, look, if I give this drug to 8 Johnnies, I will stop the outcome of interest in one of them. And that suddenly becomes more meaningful. So and in the next slide, I'm just going to show you how you do that. And then you're just going to look at the harms. Now, the harms are going to be things like side effects or costs, and it might be something that's tailored to your patient. If your patient is afraid of big pills, well, it might be that this is a big pill, or the polypharmacy. You might want to tailor it to what's relevant for your patient when you're looking at a paper. It might be all the INR monitoring, or the other blood test monitoring they need. And when you look at harms, though, you can, for common side effects, often in the study they'll tell you the frequency of side effects, and you can actually work out a number needed to harm. So, for example, if there's a 10% incidence of severe diarrhea on a medication, well, that means I've got to treat 1 in 10 Johnnies to get one patient with severe diarrhea. And so those things can be quite useful. And you can do, with costs, let's say you needed to treat 5 Johnnies to get a benefit. Well, and the drug costs $50, well, you go 5 times 50, $250 to prevent one outcome. So you can start doing number crunching, but don't forget all that qualitative stuff too, like the fact they needed INR monitoring or blood test, or the costs, or whether it's on the PBS when you're doing this. So let's have a look at the next slide just to see how we, just a little bit more about ratios converting to risk difference to number needed to treat. So here's, let's say there's an imaginary patient Peter and imaginary patient Rachel, and we know this study says there's a statin shows there's a relative risk reduction over a 5-year period of 25% in cardiovascular events. Well, if Peter's baseline risk of an event is 8 in 10,000, well, a relative risk reduction of 25% for him means that his risk now becomes 6 in 10,000. So in absolute terms, he's had a 2 in 10,000 absolute risk reduction. And then all we need to do is go 1 minus that absolute risk reduction to get the number needed to treat. So I've got to treat 5,000 Peters to prevent 1 stroke over a 5-year period. Now, in studies where they already give you the absolute risk reduction, well, it's easy just to convert it over to the number needed to treat, but you do have to ask yourself, what was the baseline risk of the patient? What was the baseline risk in your patient of having the event, and see how well it compares with those in the study. Now you can see here, just to show how the importance of baseline risk, here's Rachel. Rachel is going to take the same statin, 25% relative risk reduction, but let's say she's got a lot more cardiac risk factors, and you determine her risk of a cardiovascular event is 8 per 100 in the next 5 years. Well, the same drug is going to make her risk now 6 in 100, and the absolute risk reduction, that should say absolute risk reduction, then becomes 2 in 100, which means you've got to treat 50 Rachels to prevent 1 cardiovascular event in 5 years. So you can see how that the baseline risk is really important. So in studies where they give you an absolute risk reduction as the result, ask yourself, well, how well does your patient determine, how do they compare to those in the study in terms of their risk of the event, or the outcome in interest? And if you've got a relative risk ratio, or you can determine that from a paper, and you can determine that from papers, even those that have absolute risk reductions. Just remember that maybe that if you know that, and you know the risk of your individual patient, you can give them an individualized number needed to treat for your patient. So have a reflection on that. There's some nice Terry Shanafield talks on this topic if you're interested, and I'm sure there's other sources. And no, I don't have any shares in Terry Shanafield, I just like him. So let's have a reflection on how this paper went here. Well, in terms of the benefits, well, there was no difference between the pregabalin and the placebo at the 8-week mark for leg pain at pain intensity score over a 24-hour period. So I guess the number needed to treat in a sense is not relevant. I guess you could argue it's close to infinity because the value is 0. But and then you look at the harms that are demonstrated in the paper. In this case, the side effects are here, and this is where you can do your number needed to harm. So let's look at dizziness: 39.6% in the pregabalin group, 12.9% in the control. 39.6 minus 12.9 is roughly 26.7. That's the absolute risk difference between the two, and then I go 1 minus that, the absolute risk difference, which is translate to be roughly 4. It's not quite 4, but I'm just rounding it to the nearest whole number. So I've got to treat 4 Johnnies to give one of them some dizziness if I gave them the medications that was the pregabalin in the doses used in this study. So that's how you sort of calculate your risk versus harm. I guess strictly speaking, when you're looking at the results, you really just look at the results within the paper. And when it comes to external validity, we will look at harm in a more wider way of looking at it in terms of, that's where I guess you consider the rare side effects not in the study, and the other harms that are not necessarily in the study, but we know from outside. But we'll talk more about that with external validity. So this brings us to the last bit, which is where you reflect on pregabalin and its role in relieving pain in sciatica, in leg pain. And it's a sort of different question. The results was looking at what this particular study says, whereas this is a more holistic question where you're thinking, what does this mean about pregabalin in the world and its role in alleviating pain? It's about its causality role. We often use it in terms of risk factors too for particular outcomes, like does smoking really cause lung cancer? And it's been named after, this criteria was named after Bradford and Hill, who established it. And I'll just take you through it because you'll notice that this is what papers often do when you read them. They're not really just trying to give a result, but they're trying to tell you how this fits in with the Bradford-Hill criteria. So, strength of association, the higher the relative risk or the hazard ratio, or whatever your result is, the stronger it is, the more likely it is that there really is an effect between your medication or your risk factor and the outcome. So, a relative risk reduction of 90% is a very strong argument that whatever the medication was actually does something, whereas a relative risk reduction of 10%, less so. In this case, we had no effect. So that's obviously a big negative for pregabalin and its effect on leg pain in patients with acute sciatica. Consistency, for every negative study, there might be a positive study. So this is where you look at the entire world's literature and say, well, what does all the literature say about pregabalin in acute sciatica? And you'll notice that often in the introduction or the discussion part of a paper, they'll often tell you about all the other studies, so that they're trying to show where it fits in with the Bradford-Hill criteria, basically. And this paper does very similarly. The problem with discussions of a paper is they're more like the salesman pitch. They're sort of telling you about, they're trying to brush over some of the dings and dongs or explain them and then promote why Bradford-Hill criteria is so well met by their study. That's often what you'll notice discussions do. What's probably better to do when you're trying to establish this, when they talk about other studies showing this and that, is to do it yourself. Go into TRIP database, look up, type in sciatica, pregabalin, and see what And you look at the literature yourself and see where it fits. So that's what we call consistency, reproducibility. The next thing here is specificity. That's saying, is it pregabalin that you're talking about as the risk factor, or is it some other thing? So if a study's got lots of confounders, you're stuck wondering, well, I don't actually know what was the risk factor or the treatment here. If there is, so that's and that can be, I mean, that could be a particular problem in certain study designs where they really are not being specific as to what caused what. Temporality means that the treatment or risk factor preceded the outcome. Now that's always the case in a randomized controlled study, but you can imagine a cross-sectional study, cross-sectional survey, that might be a problem. So this paper, so far if you look at this paper, well, there's no strength of effect of pregabalin. If you do a database, you find there isn't any studies really to back that pregabalin actually works in acute sciatica. So far we've got 2 nails for pregabalin in this situation. Specificity, I think we're pretty happy there wasn't too many other prognostic variables to account for the observed effect. It's probably, again, supportive that pregabalin doesn't work in acute sciatica. Temporality, well, the pregabalin definitely preceded the outcome. Now let's look at biological gradient. Biological gradient means there's 2 ways you can look at this. One is that the greater the dose of a risk factor or a medication, perhaps the greater the effect. It's not always true. As we know, some medications actually have if you go beyond a certain dose, that actually the effect might disappear. But as a general, the greater the dose, the greater the effect. The more you smoke, the more likely you are to get lung cancer. That's one of the supportive evidence that smoking causes lung cancer. And so that's why you'll find a lot of studies will often have a medium dose and a high dose of a drug. In this case, they didn't do that. They didn't study that. But the other way you can look at biological gradient is that the longer the time that a patient's exposed to a risk factor or medication, the greater the effect. And if you don't see that, then it goes against the medication. As you'll see in the next slide, that's why they often have these graphs, you'll see that there is no separation between the pregabalin and the control group in terms of the outcome over time, which again puts another nail in pregabalin in acute sciatica for patients who are very similar to those in this study. And then the last one that's important here is plausibility. That means, does it make sense that pregabalin wouldn't work or would work, depending on what you're looking at? And it does happen. Now, plausibility can be incredibly important for some studies. So, for example, if you were to jump off a plane, I can tell you that wearing a parachute is a very good idea, but there are no studies on it. But it's so biologically plausible that we're not going to test the theory. There will be no randomized control studies on bleeding wounds and pressure, and that's what biological plausibility is. But there's a catch to it. You can often find some kind of biological plausibility to many things that actually don't work. So this study does talk about some studies to show why this might work. And I guess that helps at least justify the study. But so that might be something in favour of pregabalin, is there's some plausibility. But as I said, it's a bit of none of these criteria are perfect, and this one particularly is not perfect. And no, you don't have to have all of them. And similarly, some medications that seem to work, there's no biological plausible reason why they should, but they do. But it does make you a bit more like, do I really trust this? It's less likely to trust the result. These last 3, coherence, experiment, analogy, I'll just mention briefly. Coherence just means, does it fit in with our worldview? Does it fit in with the status quo of what we know? Only problem is that at some point someone decided the world was round when everyone thought it was flat. So that's its downside. But still, it's something you factor in. This runs counter to my gut feeling on these patients. You need to listen to that. Maybe there might be the plausibility. But it might run counter to our culture. Experiment, that's animal studies. You can they're a bit. Sometimes you can have great animal studies, but the medication doesn't work. But it still adds to the argument. and an analogy. That's where you, I guess, you think of an analogy and and see how well it fits with your theory. So just remember these top 6. They are useful. You'll notice there's a lot of this stuff that comes out in the discussions of papers, so it's worth being aware. And often when you get a journal club, this is often you get these discussions around this sort of stuff when you get a really good going journal club. This is that graph just to illustrate biological gradient. You might notice here that the longer someone's been on the medication, there's no widening in outcomes between those on pregabalin and those that are not on pregabalin, which supports the idea that there really is no effect of this medication. Whereas if there'd been a widening over time, you might think so. It also gives some medications work for a little while at the start and then the effect isn't so good. So you might find there's a big widening at the start and then it narrows, and it might be just that, okay, there's a short-term benefit. For example, giving steroids to subacromial to people with rotator cuff tendonitis does give you a short-term effect, but there's no benefit after a certain time period. And so that might tell you that, okay, you can tell your patient, well, yes, there's a short-term benefit. It seems to be between this week, and then it seems to drop away. So that's the value of this. Now, there was a question, incidentally, where we asked in this assignment, are there anything else you get out of these graphs? And I guess the only thing I'd say you get out of these graphs that's kind of useful is it sometimes tells you a bit about the natural history of something. So here you can see that the natural history of moderate sciatica in this population of people who'd been present, where the pain had been present an average of 60 days, was that people's pain scores would drop from, say, around 5.5 to about 3 with whether they were on placebo or not. And it's just a useful thing. It doesn't mean that you can extrapolate this to all patients with sciatica. It's only the people whose PICO matches the population studied in this group, which is people with moderate severity sciatica who'd had pain present for 8 weeks, whose baseline scores were in that sort of, around 4.5, 5.5 range out of 10 on the visual analog scale. So that's that. All right, so far we've done, we've gone through question type, study design, the PICO, that was YouTube trip 1. Then we've gone through Do I Trust the Results, which is looking really at bias and identifying unequal prognostic variables. So that's assessing the internal validity. And then we've just then gone through results. That brings us to the last component of looking at a paper, which is assessing external validity. What in basic terms is, how can these results help me look after my patients? In other words, the usefulness of these results to apply to patients or outside, externally. And that's what we're going to look at in this next bit on Jack, who I've been calling James, but anyway, maybe that's his nickname, so I'm not going to go back and re-record these. So when we assess the external validity, or how can these results help me look after my patient, we've got 3 things we do. The first one is we compare the PICO of the study with the PICO of James or Jack, and this brings home why we spent so much time looking at the PICO of the paper in module number 1, and why we also were interested in the PICO of Jack. So the paper, in this case, told us that was looking at patients with acute sciatica that had, I think it was an average length of pain of around 60 days. They had a certain pain score of about 5. It was they were moderately affected function-wise, who had low neuropathic scores on the pain detect score, and who were given and who were typically around the age of 50 or so, and who had radicular pain with some neurological symptoms, signs, straight leg raises, but didn't have cauda equina, who were given pregabalin at the kind of doses that I would normally be giving in Australia, with weekly reviews and bumping up the dose, starting out at 75 BD, and comparing this with not giving it, and with the outcome of interest of leg pain. And then then I reflect on Jack. I think, okay, well, Jack is a 50-year-old who came in with acute sciatica. It doesn't really say in the question how long he had his sciatica for, but that would suddenly, you can see why it's relevant. And I'd like to know how incapacitated he was, and I'd like to know what his pain detect score was. In other words, those sort of questions that you saw in the pain detector clinically suddenly become meaningful. And I would like to know what his baseline pain score is, because I'm trying to get a feel for how well he fits in. Is this the kind of paper that was talking about Jack? And then I'm going to think, well, and what was my proposed treatment for Jack? Well, it was going to be the same thing, really. And my comparator would have been not to do anything additionally. And I will quiz Jack and ask him, look, is it the pain in your leg or the back that's troubling you? And because quite frankly, if it's the pain in his back, well, this paper's not really addressing that question. Not that I'd see any reason why pregabalin would work for your back pain, but the point is, trying to work out, is Jack's PICO and the study's PICO, how similar are they? So that's the first thing I do. And then you're going to look at the harm and the benefit. Now, we've gone through that with our results. We looked at the benefit, which in this case was not really much for leg pain. And then you look at the harm, and we saw that table with all the side effects, and we were able to do number needed to harm. So we could do that. But you've got to think beyond that when you're looking at external validity. You've got to think in terms of things that are beyond, not in the paper. So I'll look up the PBS, and look at Jack's situation. How much would he have to pay for this medication? I'd look at his issues of polypharmacy. I'd look at his comorbidities and other health problems and think, well, how important are those side effects? If he's at very high risk of falls, well, those side effects of dizziness suddenly become really important. I look at the rare side effects that are not in this paper. These studies aren't going to pick up rare side effects, and there is concerns with pregabalin of things like suicidal thought. There is some rare complications, things like neutropenia and a few other rare things that can happen. And you're going to factor all of those in. So harm versus benefit is a more holistic thing. Think beyond just the paper. Although do consider what the paper's telling you. They often do give you nice number needed to harm sort of numbers. So this brings us to the last part of external validity. Is this for us this third question, which is the treatment suitable for Jack in the context of your individual clinical experience as a clinician and the patient's values and expectations. And this brings us back to a fundamental of clinical decision making, which is our decision making is actually shaped by our clinical individual experience and expertise and the knowledge we acquire from other people, and we tap into the best available clinical evidence, which is medical studies, and you also tap into the patient's values and expectations, and you pull them all three in to come out with a response to a patient, and taking in all into consideration. And so that's ultimately what you've got to do with external validity. When you think of it, trying to apply it to patients, you've got to draw all these all together. So clinical individual experience. I'll be reflecting on the symptoms and signs of this patient, the investigations and the workup, and what I know about this condition, what's worked for me in the past, and what and I'll be looking at, and also I'll have my knowledge of what the health system that I live in and my community can afford and what's appropriate, and these things can never be ignored. This is a core part of what we do. In fact, it's a critical area, and so you factor that into this decision on James or Jack. And similarly, you've got to factor in the patient's values and expectations. It might be that Jack is thoroughly a believer in pregabalin. He saw his mate get better on it, and I'm sure we know individuals can improve on these things. And he'll say, look, I want to give it a go. I just want to know if it's not what harms it's going to cause me. And in that case, it's perfectly appropriate to consider a trial. If he's happy to pay for it, and he wants to trial it, and he knows the side effects, and it might be that the value of the evidence base in that situation is more to tell him what the side effects and the harms are. You might tell him that the studies don't show it works, but I wouldn't. I try not to completely remove the placebo effect. I always say to him, look, there are individuals it might work for, so you can give it a trial. But we're doctors, and if we'd purely used evidence-based medicine alone, it would be a very sad story, because these two other areas are so critical to our decision making. But it's a terrific tool as well, and it brings some concepts of objective attempts at looking at the truth of a situation, and that can often aid our management as well. So, without ado, I'll just give you a summary slide. All right, so this is the last slide of the YouTube clip. It's just a summary. So what we've done in these 3 YouTube clips is we've looked at Jack and tried to work out the PICO of Jack or James and his situation. There would have been a process of acquiring the article, which we haven't gone into in these YouTube clips, but then we've gone to the point of, but what we have focused on is the reading of the paper. And in these 3 YouTube clips, we've gone through the process of identifying the question type and study design of the paper, thinking back to Jack or James and comparing whether the appropriateness is for answering his question type and the study design that I know would best answer Jack's question. We've then identified the PICO of the paper, thinking and reflected as we're doing that on the PICO of the patient that I had in mind and his PICO. We've then done an inspection of the paper for DENSE, which is the biases and the presence of unequal distribution of prognostic variables, which is the assessment of the internal validity, that concept of do I trust the results. We've then looked at the results. We've looked at, well, what are the results? Are they differences or ratios? We've looked at the confidence interval, and based on that worked out the magnitude of the effect or the degree of association, so how effective was pregabalin compared to the placebo. We've then adjusted the result to any unequal prognostic variables and touched upon that. We've at least made sure the result sort of seems to take that into consideration. We've then looked at the effect of chance in the results by looking at particularly the example of a negative study, as this study was, and also a theoretical example of a positive study, and where we've looked at power and numbers in the study in addressing negative studies, and p-values when addressing positive studies in terms of getting around the problem of chance. And then we've looked at the actual results and made them clinically more meaningful. In this case, converting things where possible to number needed to treat. And then we've looked at the harms identified in the study, particularly with in mind those harms that are relevant for Jack, and tried to see what the study has to say about them. And then we've looked at the Bradford-Hill criteria. So that was all in results. And the Bradford-Hill criteria being what we use to try and get an overall feel of what this medication has to say, what this study has to say about pregabalin in acute sciatica. And then we've gone to the last step. We just asked ourselves, how do these results help us look after our patients? And that's called external validity, where we've compared Jack's PICO with the patient's PICO. We've looked at the harms and the benefits, and then we've gone back to what is one of the essences of being a doctor, which is made a decision taking into consideration our own individual clinical experiences as a clinician, the patient's values and what's important for them, and this evidence base that we've had this paper tell us about, and that we've reflected on in the light of the whole Bradford-Hill criteria. So that's reading a paper encapsulated. I hope you find it useful. It doesn't just apply to RCTs, it applies to all of quantitative research. Qualitative is a little bit different in terms of exactly how you do it, and I don't have the experience with that one, and I hope you found it useful.